Everyone as well. Thank you so much for logging into our open lecture today, which is about using outcome measures for people with a brain injury in music therapy. So my name is Michael. I'm one of the music therapists. Behind me is the rest of the team, although they're blurred out at the moment. You will see them soon. Before I pass you on to our presenters, I want to just give a bit of an introduction to the Royal Hospital for Neuro-disability. So we are a independent charity funded hospital. We're separate from the NHS. We have 230 beds, and our hospital is comprised of three broad services. The first one is the brain injury service. So this is um, level one rehabilitation, multidisciplinary rehabilitation, multidisciplinary, so comprised of physiotherapy, OT, SLT, speech therapy, music therapy, and psychology. Thank you, Alice. And that is funded through NHS England contracts. So this is providing neurorehabilitation for people that have had an acquired brain injury. Our second broad service is the long-term care or continuing care service. So this is providing long-term residential care for people living with a neurodisability. And the third service is a service that encompasses lots of different units doing special things. So this is special services. And in this service, we have a a neurobehavioral unit. We have a ventilator unit, and we have I always miss out some of these, a Huntington's disease care unit, and we have a young adults unit. So yes, that is a bit of a background to the RHN. Music therapy is integrated into the hospital very much. All patients have so all patients at the RHN have access to music therapy through referral. And music therapists are integrated into the multidisciplinary teams at the RHN. So we're very closely involved in things like goal planning, assessment, ongoing review. Um, yeah, so that is kind of a broad background to the RHN, which I think is helpful to have before hearing some of the presentations today. So today we will hear from music therapist Tony about using outcome measures in in the neurobehavioral unit and how music therapy supports that. And then we'll hear from Ben Jones, a music therapist who's talking about use of bespoke outcome measures for speech expression. And then we'll hear from music therapist Amanda Thorpe and physio Brittany Wood, talking about joint work in the brain injury service between music therapy and physiotherapy. And then finally, we'll have an experiential session from music therapist Cahal Nolan. Okay, so before I take up any more time, I will hand you over to Tony Almond, our first presenter today. Yeah. How do I click it on? Okay.
My name's Tony. I've been working on the neurobehavioral unit for the last year. So I'm going to run through some of the outcome measures that we use in that service. Um, let's flick through. So the neurobehavioral service, first thing to say about it is maybe what is different to the brain injury unit is that it deals with maintenance as much as it deals with rehabilitation because we've got patients who are longer term brain injury um, and with neurologic conditions that may be degenerative as well. So things like Huntington's disease. So the things we're looking at are more around quality of life, managing the behaviors, which may be challenging, safety of the patients to the self and others, management of the condition itself, and looking at social participation. Um, The other thing to say about it is that it's transdisciplinary working, which means that we're always working together as a team. And this is kind of reflected when we first take a patient into the surface, and then we'll work as a team to make some goals around where we want the patient to get to. And these can, first of all, look the green squares are looking at more longer term goals, whereas the blue squares on the outside are more immediate goals that we can work on as a team. And within the actual music therapy team, or the music therapist who's me on the team, is the looking at data that we collect, first of all, primarily for music therapy. I'll give you an example of a chart here, which is, hopefully you can see this, which is so collecting numerical data from each group. So each patient will get one of these, and it's looking at different domains. So engagement, use of instrument, choice making, social interaction, and challenging behavior. So each week we'll give a rating to each patient. And these ratings can then be transferred into data, into visual data, as you'll see below, into a chart. And we may not be expecting that there's going to be improvement. There may well be, but we'll also see whether people are maintaining their behaviors or their quality of life. And it's interesting in this case, because we've got 3 blocks of information at 12 weeks per block. And there has been some improvement, as in shown in the middle diagram, apart from around choice making. So choice making might be an area that we choose to work on more with that patient. Another example would be working more with the MDT. This is another music group, a task analysis. So it's using numerical data, but also with more descriptive qualitative evidence note-taking each week. So this gives us a broader picture of how each patient is doing week by week. So, and this contribution to this could be any, as you'll see on the right-hand side, there's contributions from SLT, OT, PT, physios. So different members of the team will add into this data. What is probably the most useful in terms of behavior, looking at behavior, is data management platform called Mello, which is we're now using throughout the service. And what this gives us, if I just enlarge that slightly, is so we can track the behaviors of each patient in terms of the frequency of challenging behaviors, the severity of those behaviors, and the use of restraint that might be used. And so Mello goes into a lot of detail about what the behavior was, where it was, what kind of restraint was needed, so things like that. And that data is input by different members of the team by each event that happens, and therefore you can class the severity of it or where it happened, and that all goes into that graph that you saw earlier. Within the MDT team, we also use off-the-shelf outcome measures. So each one, I'm just going to pull all those. So each other discipline have their own sort of outcome measure that they'll use, but the whole team will contribute towards this data. And for an example, I think SASNOS is one of the ones that's used the most because that's a neurobehavioral outcome scale. So we would all contribute towards this, and then therefore that information would go forward into this kind of image, which would give us a sense of how people were on admission compared to what they were on discharge. So in this case, we can see that there's been quite a change. some positive change, some not so positive, but certainly in terms of interpersonal relationships. So this is all very useful in terms of the whole MDT. I suppose the big question is, well, how can music therapy be shown within these collaborative outcome measures? And I suppose the best way to sort of talk about this is to consider how we would find correlations between the music therapist and music therapy analysis and the MDT outcomes. So what we're looking for is any events where there is a correlation between what happened in the music therapy group or during that time and what was happening in the wider MDT outcomes. I mean, an example of this would be if we go back to the behavioral measures. This was an individual I started working with just before Christmas. I didn't see them over Christmas, and we sort of settled into a therapeutic relationship through the early part of the year. And you can see that there were a few events that happened around the Christmas time. We started doing some songwriting together and worked more regularly together. And this led to, I'll just widen out to the last year of this patient, where there had been lots of events. And this was the first time we'd had no challenging behaviors from this client. The other thing to say is that this patient hadn't done any other therapeutic work with anybody else. So we can make some assumption that music therapy had an effect on their behaviors at that time. So the other thing to not forget is the qualitative evidence and how important that is. And one of the things that the an SLT said later last year, and this was a quote, that one of the best things about music therapy here at RHN is that when a patient is, sorry, I can't read that because it's in the way. No, I can't see.
Just guess.
It might be the only thing that they engage in, and it could also encourage them to be motivated to engage in other therapies. So I think it's really important that we do, and this was another patient that's just been discharged and what they said about that. Realize I've got a minute left, so I'm just going to round up a bit of what we were talking about. So outcome measures, the approaches to support music therapy interventions. We've talked about specific observation, group analysis using numerical data, but then also talking about more descriptive data. Behavioral data collection, as we were just talking about, there's those off-the-shelf MDT outcome measures, but they mean the most when you make that correlation with the MT data and the MDT outcomes together. And not forgetting, of course, the more testimonial reporting, which is in many ways just as important. So that's me for now. We're going to bring up Ben from the behavioral, no, from the brain injury. No, I was doing behavioral. So he'll give you an idea of how they work differently. And are you ready, Ben?
I'm ready to go.
Thank you very much.
Go. Just as a quick thing, hello everybody. I'm Ben. Just as a quick thing to mention, at the end of this presentation, we're going to do a Q&A. If you put your questions for the Q&A at the end of this in the Q&A tab rather than just in the chat tab, it'll be a little bit easier for us to sort of like be able to track your questions and keep up with things. How do I go back? Yeah, sorry. Yeah, so my name's Ben. I am a fairly newly qualified music therapist. I qualified in 2024. I've been working at the RHM for just under a year now. I was going to try, oh, there we go. So I'm going to sort of present a bit of a case study to sort of like maybe think about how we can creatively use outcome measures. I'm talking about this in context of the young adult ward in the long-term care service. I'm going to talk about via a case study a way that I used bespoke outcome measures to measure the progress of a resident that I was working with on the service. So just like for a little bit of context about outcome measures and music therapy, like why do we use them? I think for me they provide like a really sort of like tangible, visible way of sort of being able to like interpret the therapeutic intervention, which can be useful for when we work in medical settings like the RHN. They're very useful for sort of like justifying our place within the MDT. But not only that, I also feel like they can be really useful for some patients as well to have that visual representation, particularly in sort of the neuro rehab side of things. But sort of when you're doing more kind of like qualitative work and like the therapy process is a little bit like less linear, less goal driven, more patient driven. When I was sort of like studying to be a music therapist, I was sort of like encouraged to ask the question a lot like, are outcome measures therapeutic? And I think, you know, in some settings, you could argue that they're not, and some people's therapeutic processes mean that they might make a choice not to use outcome measures, which is fine. But I think it's also like in certain settings, I think we have like a little bit of freedom to use them like quite creatively. And I think it's important to remember that you can, even if you are using outcome measures, you can still be very like person-centered and approach every person as an individual. Which kind of segues into the question like what is an outcome measure, or maybe for the context of this presentation, like what can be an outcome measure. Because I think it's very dependent on the situation. You can vary from something like very standardized, such as like the music therapy style, just for an example, to something very like bespoke and individually created for the person that you're working with. And just to sort of like go into that a little bit more, if you're in a therapeutic intervention with a resident or a patient, and you ask them at the beginning and the end of every session how they're feeling, and you write it down, that's an outcome measure. So even something as, you know, something that we will probably do anyway, sort of just making a note of that and creating data from that, that is an outcome measure, and that is something that we can use. So following on from that sort of like vein of thought, I'm going to jump into a case study of a patient that I am working with on the young adult ward. He has a primary diagnosis of cerebral palsy and hydrocephalus, which is an accumulation of fluid on the brain. He was admitted to the RHN after recurring hospital admissions whilst he was living at home with his parents. He was internally transferred to the ward that I work on from the ventilation service as he was as his health was starting to improve. And to support that transition, he was referred to music therapy to help facilitate that. And the goals were sort of like to sort of encourage communication with the therapist, but also be sort of trying to support the way that he interacts with the other residents on the ward. I took like a bit of a combined approach. I integrated some like, you know, like standard psychodynamic principles, just sort of like trying to make everything as consistent as I could, and used some NMT techniques to sort of like sort of facilitate speech. And whilst the music therapy sessions were underway, Mr. T had an adjustment to his VP shunt, which is what drains the fluid from the brain. and we started seeing like really sort of obvious improvements. And I was sort of just able to like track the number of words that this patient was able to do when he was phrase completing. And I just kind of like started writing it down. And if you look on the right, you can see the number of words like increased within 6 weeks from like being able to do like 3 or 4 words to like 28 and like basically the whole verses of songs. And by writing this down and sort of like putting it into a spreadsheet, I was able to clarify to the MDT in the team meetings just sort of like the level of improvement that we were seeing. And also, if you take just a little note of there's a big dip in the data. I will come back to that because I think it illustrates another point as well. So this is also really a bespoke outcome measure as well, because I think this was developed here at the RHN, the group thing, right? So yeah, this is again another example of a bespoke outcome measure that we use to measure progress here. And again, similar to the neurobehavioral unit that Tony was talking about, we have different criteria that we can use to sort of like track patients' engagement. And again, I'm going to draw attention to just like a little dip here, um, which matches with the dip on the other graph. Basically, the patient had a cold and wasn't engaging as well that week. And it was really sort of useful for us to be, again, in like an MDT meeting when you're sat discussing patients with a few clicks, you can sort of bring this data up and it takes it from being an anecdotal oh, something's not right to okay, well we can see it and here's things to back up what we're seeing. So using both of these together are ways that we can sort of use outcome measures in these services. So what is the outcome? Um, I think it really helps music therapy be part of something bigger. Um, I think it's an interesting case study because we're not saying here, oh, look at what the music therapy intervention did. We're much more thinking about how it can be contextualized and integrated into the way that the hospital provides for its residents. But what we're essentially saying here is like, okay, look how music therapy can show what this other intervention did. And I think that's like a really nice way to think about it. And it shows how useful music therapy can be in teams and in settings like this. As I was saying before, it helps the MDT move from something anecdotal to something solid. Like a lot of times you'll hear maybe people in these meetings say, "Oh, like this patient, they just don't see themselves." I can say from this data, oh, like they're speaking less, or oh, they're less alert, their arousal is lower because of the parameters that we're checking, or they're saying less words, and it's something really concrete that we can that we can offer, which is really useful. And just as a nice little way to round off, I sometimes with case studies, I watch people do case studies and I'm like, what happened to them afterwards? And yeah, Mr. T is very much still accessing music therapy and he is singing like full songs by himself, and that is more words than I can reasonably count. So my graph kind of is a little bit redundant, but in a really positive way. Um, Thank you very much. I'm going to hand over to Amanda and Brett, who are going to do a joint presentation. Thank you.
Thank you, Ben. Hi, my name's Amanda, and
Hi, my name's Brittany.
Brittany is the physiotherapist who made the referral, the case study that we're going to present to the music therapy team, and we hope that it helps shed some light on the joint working and how we measured it. I need to know which page, which button. Okay, thank you.
Great. So what we'll be presenting today is one of our patients that we jointly worked with together. Just a bit of information about this patient. She was a female in her 50s. She had the diagnosis of a left frontal parietal temporal stroke, which Amanda will talk about shortly, but it affects a large area of the brain, and that can have different implementations on how that presents. So her presentation, mostly due to the location of the stroke, presented with dense right hemiparesis and spasticity. So all along the right-hand side here was dense weakness and some tightness along there as well. Communication, she had aphasia and apraxia of the speech. So not only was that how speech was interpreted for her, but also the motor aspects of it as well, and how she could produce that speech. So communication was quite a difficult point for us and a large reason for the referral. Cognitively, she showed slowed information processing and impaired memory. And throughout our sessions, she showed heightened anxiety. The language was significantly limited. She would often repeat the phrase, "I can't place myself," which we'll talk about a bit further in.
Just so you know, Angela, we are using the name Angela. That is a pseudonym. She has consented to us sharing this information and case study. So just breaking down the brain injury that she had, the frontal cortex is very significant in our higher cognitive functions, so our planning, problem solving, decision making, whereas the parietal lobe is very integral to sensory information processing, our spatial awareness, visual spatial processing, whilst the temporal lobe is more auditory processing, language comprehension, memory, and working together because there is a temporal parietal junction where all these elements come together. The networks are highly integrated to provide this overall sense of self, where we are in space and where our body is. So digging into that proprioceptive aspect of this sort of highly concentrated network, which is really where her injury had affected, the proprioceptive part of our body schema, it's also known as our sixth sense, but it's really where our body gets muscle feedback, and all that information goes up and helps us know where we are in relation to other people, other objects, where we are physically, what our body is doing, and which sensations and actions we own and are initiating. This ongoing sense of body ownership and agency is really integrally sort of tied in to your proprioception, and disruptions to these networks we started to understand were quite succinctly captured in Angela's perseveration on the statement, "I can't place myself." This was used in so many different contexts. We didn't really associate it immediately and automatically with her sense of body schema, but definitely in physiotherapy, it became very apparent that that was what she was struggling with.
Yeah, so some of the challenges that I was finding in her rehab journey was we were plateauing, we were getting a lack of progress because of the physical, cognitive, and emotional factors as listed. It was very clear that she was very anxious, saying, "I can't place myself, I can't place myself." This was getting in the way of our progress with the standing, stepping, any transfers. There's a lot of steps that go into each of these things. And because of the cognition and the anxiety, a lot of these tasks were just becoming more and more difficult and increasing the anxiety around that. So I did put in a referral to music therapy to see if we could increase her confidence, reduce anxiety, and increase engagement.
So one of the things about being level 1 rehab is that we're really trying to find very sort of concrete ways to reduce the ongoing care burden and needs, which is what happens through increased independence. So for the patient, it's really positive because they are becoming better and more independent. And then for the reduced care needs, you need only one carer rather than two. And so with the referral, it was clear that we needed to try and really help reduce the anxiety, to increase her engagement with the physio to progress in those goals. Sorry, I jumped ahead, didn't I? In our first session, we noticed that there was this I can't place myself situation, and it really started to become apparent that as Angela was trying to stand, she was very, very anxious as she couldn't figure out where to put her hand or her arm or where her body was. So we decided to do individual sessions, so we could really, individual music therapy sessions, so we could work on various strategies to improve that body awareness, and then go into the joint sessions together so that we could transfer those skills over into the physio. So with the individual sessions, we had primed Angela through body scans and pressure feedback. And then when we went into the joint sessions, we started doing the same thing with Brittany.
Yeah, and because of the cognitive issues, the repetition and the increased frequency of these sessions that she had gained from the individual sessions, I felt a real carryover into the physio sessions. We had some strategies to reduce the anxiety, and as a result, we found increased engagement through that. So we could work towards the goals of increasing independence, standing, and transfers.
And so our outcome measures.
Yeah, so we use a combination of the standardized outcome measures, and we use our own bespoke outcome measures as well. So one of our main ones, we wanted to choose ones that were relevant and for her goals. The FIM-FAM was one that we can use. It's a functional independence measure that goes into how much assistance she requires, any equipment that she needs as well. So this was relevant towards her journey from a level 1 rehabilitation to her goal of getting home.
We also did the state trait anxiety inventory, which is the middle section. And this was where we were having individual sessions and we were monitoring her level of anxiety. The blue line was at the beginning of the session, so she was showing heightened anxiety. And then after the work that we had done with proprioceptive feedback, the anxiety at the end of the session was lower. Where it goes up in session 2, there was an external contributing factor to that, but overall you can see that the general trend was down. She felt far more confident with those grounding exercises and that proprioceptive feedback that we were giving her. You may be wondering where the music was. We were doing this all grounded with very specific rhythm, tempo, sort of subliminal support around all these things, providing those musical cues which released or reduced the cognitive burden that she was experiencing. And so you can see in the actual individual scores, the biggest differences were her reduction in feeling tense, her reduction in feeling nervous, and her increased sense of feeling content.
Right, so some of the clinical implications, working together, it allowed sensory integration, emotional regulation, and functional recovery to be addressed together rather than in isolation.
And our key takeaways, we broke through that barrier of engagement to physiotherapy, and she left and she was able to return home rather than to a care facility. And we're going to hand over now to Cahal. Thank you.
Okay,
Hello, everybody. My name is Cathal. I am one of the music therapists on the brain injury service here at the hospital. Also like Ben, I am quite newly qualified. I qualified and trained in Ireland and moved to London, and I find myself here. So I guess at this point in the lecture, you've kind of all heard about outcome measures, what they are, and like why we use them in our service. So I have been given the task of giving you guys the task of experiencing outcome measures instead. And kind of a brief discussion on the complexities and the challenges that I suppose present with outcome measures um, and what they tell us. Like I said, yeah, I work in the brain injury service. We typically see a lot of patients who present in a prolonged disorder of consciousness at the beginning of their admission to the hospital. And during their time here, typically there's a lot of changes that happen within that presentation. Whether they are emerge from a prolonged disorder of consciousness, they remain. But that's why kind of using outcome measures within that space is really a bit beneficial, like Tony and Ben had discussed. So, I am going to ask all of you, wherever you can, in your head, on your phone, on a piece of paper, to do a little self-rating. Take 30 seconds. In how settled do you feel in this moment? Just to make a note of it on a scale of 0, which is not at all settled, to 10, which is completely settled. I'll give you a few seconds just to do that. Get a little. Okay. If everybody is ready, I am going to move on to our experiential. I am also going to change my audio to original sound for musicians, hoping that you can hear a guitar that I play. Also meaning that everybody in this room has to remain completely silent. I might just do, if anybody can give me like a thumbs up that they can hear this guitar, okay? Will I see any reactions from here? Can you see that? Any there? Yeah? Okay. So you guys are welcome to sing, hum, tap along, move, or just listen wherever you are, whatever is appropriate in the current environment you're in. Okay, I'm going to do another little musical musical excerpt. I'm hoping this isn't too loud, sorry. Okay. So I want everybody to now take another little self-rating in how settled you feel right now. Whether or not that was an awful experience for you or a positive experience for you. If it changed how you feel in your body, how connected you feel to yourself. I want you to just take note again. Okay. Um, so now this is the interesting part of a live outcome measure taking or outcome measure experience, and asking you guys what changed. I will ask for your participation in this element of my presentation. Just with like a little quick hands up. I'm not sure that I can see the hands up, but Anna could probably count them for me if, yeah. Okay. So, being honest, I want to know, did anyone's score increase?
Yes.
Okay, scores increase. Good. 9. Okay. I guess that's a good thing. We'll take that as a good thing. Um, you can now take a thumb down, and I also want to know if anyone's score decreased. Whose score decreased? Be honest. 2. Okay. We won't name and shame, it's fine. Um, I can't be biased like that and influence the outcome measure scores. And I also want to know, did anyone's score stay exactly the same? 4, 5. Okay, stayed exactly the same. And then the last thing I suppose to really kind of think about is what influenced your score. Um, I don't know if we have a chat on it now. If you guys could at all put into the chat what exactly influenced your score. Obviously, it was the music and the experiential and what you heard and experienced, but where and what changes did you notice in your body? Was that your heart rate or your breathing? Was that tension in your body? Was that like feeling some sort of emotion? Did any memories come back to you? Did you have any imagery? Did your energy change? Did your mood change? Maybe even attention? Did you find yourself more attended? Was there any distractions for you within it? Did your phone beep? Did you get an email? Did something distract you from being, I suppose, within your body and connected as well? Um, I would love if you guys could give us something in the chat. That would be great. Hmm? Or the Q&A, if you need a little time to think about it, yeah. Is everybody very shy? Very shy. Oh, okay, no problem. Maybe we can talk about it in our Q&A then. Cool. But yeah, it's obviously always an interesting thing to think about in what influenced your score. And if I like kind of put that into my clinical work here at the hospital and let's say one of my functional music groups that I run, there's often very differing kind of genres of music and contrasting pieces of music that a lot of people within or a lot of patients within the group would choose. And within that group itself, I use a mood scale, a very simple mood scale of kind of high, middle, and low. So I take a check-in at the start of group and a check-in at the end of the group. But often I kind of think in my head of what each patient experienced within the group and how it's affecting or how it has affected their check-in on their mood scale, whether that's high and whether that's middle or whether that's low. And some of you might, I suppose, from looking at the complexities of both case studies that you experienced today or a lot of the outcome measures that Tony introduced you guys to, that they're a lot more complex than just three simple options of like high, middle, and low. And I suppose that's why across the hospital we have so many patients that present in so many different ways. And I have kind of found that this check-in here with my particular population group is the most applicable. A lot of those patients would present with cognitive and communication impairments. And this is kind of the easiest way to check in. But sometimes just like that, you guys experiencing those excerpts that I just played for you can really influence it. And sometimes those patients might not be able to communicate with me why they started off in the middle and now they're high, or why they started off in the middle and now they're low, and vice versa. So I guess it's kind of puts it down to one number can't really capture an entire person's experience of a music group, of an experiential. Um, so yeah, it's kind of no means perfect. It's just accessible and digestible. And yeah, I found this little quote for when I was doing the doing up this presentation. Outcome measures provide one perspective on change, but they cannot fully capture the richness and complexity of a person's experience. And I guess therefore our challenge as therapists is deciding what to measure, how to measure, and recognizing that no single outcome measure captures an entire experience of any one patient, of any one individual. And I think that is pretty much me. Thank you so much.